have in chat. I think she would be happy to stick around for a few more minutes.
I will.
But in the meantime, in the meantime, it's been such a pleasure, and I'm sure your remarks will be valuable for many of us aspiring to work in the field. But speaking of change, we have a very special panel next with some of the brightest experts in the field. Although we are a long way from achieving our goals for universal and equitable access to care, and we are certainly beginning to see some change across every sector, including medicine, public health, and even the private sector. And so we've learned so much from the pandemic, and we're beginning to realize that our conventional approach to global health needs to change, just as Ms. Lander has emphasized. And so our next panel will expand on just that, global health in a post-pandemic world. And so I'd like to introduce our moderator for this discussion, Angelina Sassi. Angie graduated from Northeastern in 2015 and formerly served as a project coordinator in Africa at the Institute for Healthcare Improvement, and is now completing her MSc in epidemiology at McGill under Dr. NUGHI. Angie, it's all yours.
Great. Thank you, Andrew, for the introduction and for everything you've done to organize this conference. And I also want to make sure to thank Crystal Lander for an amazing keynote presentation, in particular for urging us to speak up and intervene when we see microaggressions, systemic racism, and injustices of any kind. I think it's really up to us if we want to see that change. So for the sake of time, because we have a very exciting panel coming up, I'm going to jump right into some abbreviated introductions, and then we can begin with the questions for our panelists. So throughout the panel, please add any questions you have in the chat or the Q&A box, and we'll have time set aside at the end to answer those. So I'll begin with Ms. Tiaji Salam Blyther. She is a global health specialist at the Congressional Research Service, where she has extensive experience facilitating negotiations, advising Congress, and managing development projects worldwide. Ms. Salam Blyther is a thought leader with an outstanding record in facilitating and coordinating high-level negotiations, managing international development projects, and guiding cross-cultural information exchange. We are pleased to bring her critical insights on development to this conversation. Next, I'll introduce Mr. Charlie Petty. He is the principal and co-founder of Adjuvant Capital, a novel investment firm committed to accelerating the widespread availability of high-impact innovations in global health. We look forward to hearing his insights on the emerging role of this sector in the field. And finally, Dr. Mark Dybel is the co-director of the Center for Global Health and Impact at Georgetown University, a well-recognized global health expert and humanitarian. Dr. Dybel served as the executive director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and as the U.S. Global AIDS Coordinator, overseeing the implementation of the U.S. President's Emergency Plan for AIDS Relief, also known as PEPFAR. So with that, I will start with our first question, and I believe we can have any panelist start with answering this, but although the pandemic has been less serious than anticipated initially in the global south, with disruptions in education, the economy, and healthcare while medicines remain inaccessible to low and middle income countries, where are we now in the global response and what comes next?
Okay, well, I'll jump in. Hello, everybody. I have to say first that all the views and opinions that I reach here are my own. I am not reflecting CRS in any way, so none of what I say can be attributed to CRS. This is my personal experience and expertise, okay? So having gotten that out the way, you know, I've been working in this space for about 20 years now. And so I've had my share of outbreaks to monitor and work on with the Congress. This one has been quite unique. And I think one of the biggest factors that make this so unique is the impact of misinformation on how we address this pandemic. For many outbreaks, there are always fringe groups or some groups who question the legitimacy of the science and what we hear. But what's different in this one is that there are actual world leaders who are accepting the misinformation, who are questioning the science. And in my opinion, it's really making it even harder to control this pandemic. So I'll say that quickly and leave it to my other colleagues to add more.
So maybe I can jump in on where we are in the global south. I'd actually challenge your first assumption that it hasn't been as bad. It wasn't as bad in the first wave. So in the first wave, it wasn't that people weren't infected. So we know that, and I'm going to focus on Africa because that's where I spend most of my time, but people were infected at very high levels. So 30% of Johannesburg, 20 to 30% of Johannesburg, 20 to 30% of Nairobi were infected. So the rates were quite high, higher than any we've identified in the United States, really. And some of us predicted this would happen. There wasn't a lot of hospitalization and death because the mean age is 19.7. So it's a lot of young people. And so we didn't see the hospitals getting overwhelmed, although if you talk to physicians on the ground, they were definitely seeing cases. It was the second wave, the more recent wave. For those of us who come from the United States, we've never had a wave. We just have a massive wave that keeps cresting higher and higher because our appalling response from the last administration, non-response from the last administration. Fortunately, we're now actually doing something about it. So we've never had waves. We've just had this massive tsunami that just keeps getting bigger from time to time. In fact, I would say that we're also thrilled that we're settling at 40 to 50,000 cases a day, which 8 months ago was our greatest fear that we would get to that level. But in the second wave in Africa, the South African variant changed all that. So if you draw a line from Mozambique across to Namibia, basically from west to east, and below, the South African variant really took over. And for those who were on the ground at the time, and I was constantly in touch because we work in a lot of those countries, it felt like HIV/AIDS all over again. The rates, for example, let's just take Eswatini, a small country, so it's easier to understand. They were running around 20 cases a day. They went up to 350 cases a day. This is a country of 1.5 million people. So they quickly overwhelmed their health systems. And because they quickly overwhelmed their health systems, people started dying because they couldn't receive care. So they would literally meet at night, the ministries of health, and run through which clinics, which care facilities were going to run out of oxygen, and therefore how many people were going to die overnight. Because of old Trump administration policies, no money from the US government, PEPFAR, was allowed to be used for COVID. So we were sitting there with hundreds of millions of dollars in the region for HIV, and the last administration said, you can't use any of that for COVID. So all these people were dying because they couldn't get oxygen, which we could have helped with a lot with. So it was overwhelming the system. So the prime minister, a 52-year-old man, but had diabetes, incredible man who was changing Eswatini, died. 3 other ministers died. Several ministers died in South Africa. 4 ministers died in Mozambique. Now, I'm not saying the ministers are no more important. I'm just giving you a sense that if the people who are at that level in society are dying, it gives you a sense of what was happening below. And so we don't actually know what the overall death number was because so many people just stopped going to clinics because there wasn't anything for them there and they were dying. So not only was the South African variant, is the South African variant more infectious, it's more deadly. And so the second wave was horrific. And so I just wanted to give people a sense of that. And if everyone in countries in these areas had someone in their family or a close friend who died. And if you talk to them, it reminds them of the early days of HIV/AIDS. Why is that? Well, because the world has not responded at all to this as a global epidemic. This is a global epidemic. You have to have a global response to a global epidemic. And we have been, the nationalism and the I'm not doing anything for anyone else till I'm taken care of attitude is just appalling. And it's from a humanitarian perspective, it's indefensible and inhumane, and really not the best of who we are as a human race. But it's also just stupid from a pandemic perspective, because we now have variants in Brazil that we're not sure our vaccines will cover. The South African variants, some of the vaccines don't cover very well. So if we have these, and some of us predicted this last February, if you allow a virus like this unfettered ability to move all over when you know you're infecting 30% of the population, and young people who are probably putting immune pressure on the virus because they're okay, that you're going to get these variants, and these variants are going to actually risk our health. So not only is it unconscionable what we have been allowed to happen, and almost no one knows about it because no one's actually talking much about how bad it's been, but it is just stupid if we think we want to control an epidemic, if you're allowing this to happen all over the world, because it's going to come back and hurt us. So things are getting better now. The countries actually they're very smart. I would say the continent of Africa has done better than any other region in the world of coming together as an international, as a regional effort. The Africa CDC, John Kengasong, has been outstanding. President Ramaphosa was chairperson of the African Union. He brought together heads of state collectively for a response. They're unifying how they respond. It's been and no one's talking about that either. They actually are the model for the world of what you can do regionally when you actually act together. But we're in bad shape, and the vaccines are, we're basically hoarding vaccines in rich countries. We all have 4 to 5 times more vaccines ordered than we need. And now what we're doing is we're keeping the mRNA vaccines for ourselves and for our boosters, because I don't know if this disease is not going away, it's endemic. We are going to need annual boosters, which means we need 5 billion doses a year for the world, as far as we can tell, for the future. And we need 10 billion if you're doing 2 shots to vaccinate the world. But 75% of the world is 16 and older. So what's going to happen and is happening is the rich countries are going to hoard the mRNA vaccines for boosters, so that because they're easy to modify for the variants, and send all the other ones that are a little less effective potentially, and against the variants could be less effective. And we're sending those, and we'll send those. But we're still going to have poor coverage, which is going to lead to more variants. So we need production of mRNA vaccines in Africa, in Asia, in Latin America. And if we don't do that soon, this epidemic could get back out of control. Well, it already is out of control in our country, but get really out of control in our country again.
I think Mark took all my good points on vaccines, because that's kind of where we're coming from, is, we invest in vaccine companies. I mean, I think going back to the original question, where are we now in the global response? The European Union is kind of in the press recently as having a, horrendous response to the pandemic in terms of getting vaccines. I think they're at, 12 per 100 people in terms of shots in arms. The US is at, something like 35, which is great, but not great enough. I think Africa, according to our world and data across the continent, is less than 1 per 100. So we're talking about, orders of magnitude off. I think I totally agree with Mark's point. We're treating vaccine stockpiling as if it's a finite resource like water or weapons or some kind of commodity, when the epidemiological modeling would suggest that we need to actually really look together as a globe, as a society, and say where are the most vulnerable populations. Those populations need vaccines first. I mean, I'm really thrilled that I'm going to be getting a vaccine in the next month or 2 here in New York, but just practically speaking, like, I should be very low on the global totem pole here, and we should be thinking about this as like a real kind of commons situation. The variants aside, even just as kind of the core, the core virus, we're just not doing it right. And the idea that we're hoarding something like 30 million AstraZeneca doses now, and it's not even approved in the US, is unconscionable, among other things. And so I think the global response to kind of, to further on both of the panelists' points, it's not great, and I wouldn't consider it necessarily global. I think we've done some interesting things with COVAX and other efforts to kind of pool resources for low-income settings, but it really hasn't been a global response. It's been a very nationalistic, largely driven by rich countries hoarding vaccines, and we just have not figured out a way to leverage the amazing innovation that happens in wealthy countries across the globe in a way that is, equitable and practical, given the fact that this is a viral pandemic. This is not a, chronic disease where we need to hoard medicine. So it's incredibly frustrating. I think I agree with all of Mark's points. I don't have much more to add there besides that, but coming from the vaccine R&D side of things, a good question to ask our leaders, I think, whether it's the Biden administration or others, is, are we ready, for the next, are we better prepared today than we were in March of last year for the next pandemic? And the answer is maybe slightly. And then are we ready to produce the 5 to 10 billion doses a year we need that Mark mentioned, assuming COVID becomes kind of a chronic seasonal viral infection like, influenza? And the answer is not really. Most of our production capacity is this kind of, significant ramp up. We're shutting down facilities, working on other vaccines for COVID. mRNA has a ton of, challenges in terms of manufacturing. We probably need to, we talk about this later, but including, low-income country vaccine manufacturers, of which there are many, and many of the best vaccine manufacturers in the world are in, the global South. We just have not kind of improved this in a way where we're going to be able to manufacture the doses we need for this pandemic or the next one. And it's really disappointing. So I would say, where are we now in the global response? We're not in a great place, even if the numbers start to, are starting to look a little bit better in some places. And that's unfortunate.
Angie, could I just add a little bit to what they just said? This
Please,
issue
yeah.
of equity. This issue of equity is not new. We've seen it with several pandemics. It came up with H5N1 bird flu. It came up again with H1N1 swine flu. And after the swine flu, the World Health Organization and the members of the World Health Organization said, never again, we'll never do this again. We'll never nationalize a public good like this, right? And so they came up with the pandemic influenza framework. And that framework was something that the world agreed and said, look, we are going to share information. We are going to share resources. We won't do it again, right? And so the problem is that that framework applies only on influenza viruses. And it applies to influenza viruses because all the scientists thought the next pandemic will be some type of influenza virus. But out came, COVID. And so since COVID is not an influenza virus, all of that 11 years of global negotiation to come up with this shared resource plan means nothing. And so we're doing the exact same thing that was done in previous pandemics and previous outbreaks. And it's unfortunate. It's not as if it's like, well, what do we do now? We already know what to do. It took 11 years to negotiate what to do, but it was for that particular virus. And so until we as a world stop and say, you know what, I'm connected to you. Your health is my health is your health. I am not more important than you, and vice versa. What do we need to do as a planet to survive? Until we get that new mentality, we'll just keep cycling like this. And unfortunately, because of what's happening in the environment, all the science is showing that the outbreaks will get bigger, the diseases will get more severe. So I hope COVID is the one that we will learn from, but it doesn't look like it. So I just wanted to give that perspective that these issues that Mark and Charles have raised are not new, and it's unfortunate that we're repeating the same cycle.
Great, thank you so much. Yeah, I think on this first question, we've covered really a huge breadth of knowledge in what you were just saying, Tiaji. It's our field needing to move away from this siloed approach to global health and really looking at health systems, health as a sort of continuum, and not just pandemic, not just flu, not just COVID. So just really appreciate that. And I also appreciate everything everyone has said to sort of challenge that narrative that low and middle income countries have fared okay, because clearly the way that has been conveyed is a legacy of a lot of really pervasive injustices in the world. And I wanted to just talk briefly about the legacy and impact of colonialism in this conversation. So it would be sort of remiss if we didn't address this. And we touched a little bit, but how is this manifest in the global COVID-19 response, and what needs to be done in particular to address these problems?
Yeah, I mean, it's a tough thing because it's so pervasive, right? If we think about what is the global, or what is the kind of enduring impact of colonialism, or these global superpowers kind of dominating the global South over the past several centuries, like it's kind of a guns, germs, it's everything, right? And we talk about poverty, and we talk about those kinds of things driving so much of this. I mean, why is it the case that the European Union is able to negotiate on behalf of this bloc? It's a very wealthy place. They're able to, I think that's some degree, it comes down to just wealth and power in the world. And, it's, I think Mark made some great points around the African Union coming together in a pretty remarkable way. But, in terms of negotiating with Moderna or AstraZeneca, they obviously were not able to leverage in the same kind of resources that, the United States or Europe would be able to. And so, as long as we kind of have this, purely kind of fend for yourself market-based system for allocating vaccines, and I think there's some really, really good use cases for markets in the global health space. The lasting, effect of colonialism is you have, a slew of countries who've had tremendous damage to them for centuries, and we're expecting them to compete on the world stage to buy on the open market for, compete on the open market against the United States and Europe for vaccines. I think there are mechanisms like, the Gavis, not for COVID, but there are these interesting kind of mechanisms for pooling resources and, directing demand towards industries so they can respond kind of in aggregate. And I think those are great. But the lasting, legacy is you have, poor countries that suffer from the ails of poor countries and are unable to get the vaccines they need. And at the very least, and I'm coming from a vaccine perspective, but I think that probably applies to health systems and, responses beyond the vaccination piece. So, Mark mentioned the oxygen thing. So I think, I think it's pretty pervasive, and I don't know if there's like a policy solution. It's really, broad-based.
When I think of colonialism, I don't just think of racial inequity. I think of resource extraction, right? So in order for colonialism to work, European countries extracted resources from, the global South to enrich themselves. And the legacy of colonialism, in my mind, is that that structure has largely remained unchanged. The resources still remain concentrated in Europe. And so we're in a situation where countries still have to turn to Europe for fill in the blank. You see the rise of countries like India, China, Japan, South Korea, Thailand, who are working tirelessly to try and level that playing field. They are partnering with other countries in the global South through South-South cooperation. And so that's trying to level the playing field and change that narrative a bit, where it's always Europe and the United States, who shape the dialogue and shape where, produce the resources and distribute the resources. And that to me is a lasting legacy of colonialism. It is where the resources are generated and where the resources are produced. We talk about vaccine manufacturing capacity that still is primarily in industrialized countries in Europe, Australia, and United States. So until you change that dynamic, when we just had the whole thing at the WTO on intellectual property rights with COVID vaccines, until we change that, there's not going to be a space for these middle income countries to jump into the fray. So to me, it's about resources.
Yeah, sorry, go ahead, Mark.
Well, I'll probably get in trouble for this. Intellectual property is not the problem right now. All of the companies have said that they will not enforce their patent rights during the pandemic. And Pfizer's made it clear. Pfizer's gone through this, and anyone else who produces, certainly Johnson & Johnson's trying to get 50% to the South. I'm worried about it longer term. Not short term, because if someone wants to go produce, they can. The problem is capacity and tech transfer. These companies can't keep up with the demand from rich countries, so they can't produce for lower income countries. And that's really where the problem is now, which is not to say intellectual property isn't an issue could not become an issue, but that's not the issue right now. It's fine to talk about it, but it's not what's keeping us from getting products to people in low income countries. So I'm actually around effort. I'm not worried about intellectual property. I'm worried about capacity and resources to build mRNA facilities. And I think we should go for mRNA facilities, not others in Africa. The problem with the Johnson & Johnson vaccine, which is a good one, is it's an AAV vaccine, and we create antibodies to AAV. It's a viral vector. And so you can only really use it maximally effectively once unless you modify the vaccine. So, and mRNA can be used for lots of other stuff, potentially for the long term. So that's the kind of capacity we need to get and build in Africa, and we have the opportunity to leapfrog. I just touch on colonialism a bit because we have these wonderful documents in development, starting with the Monterey Consensus, about changing the paradigm from colonialism, which has been deep in development for a long time, to partnership. And actually, it's really service. We're there to serve other countries. But the colonialism is still so deeply entrenched, that mode of thinking that we will come and save, that we are the saviors, and when we get around to it, we'll come take care of your problems, which is the opposite of the truth. The innovation, whether it was through PEPFAR, the Global Fund, the work, I've been so privileged to work in a lot of these environments, and the real heroes are there. I mean, they're the ones who figure out how to implement. They're the ones who figure out how to get vaccine into people's arms, get drugs into people's mouths, how to bring communities together. South Africa fielded 28,000 community healthcare workers community workers to go do test and tracing, when the US had less than 20,000. But they had to stop because no one would give them test kits. So they couldn't do contact tracing because they didn't have any test kits. Sierra Leone fielded 9,000, a tiny little country, because they had Ebola, which Tiaji mentioned this, the Asian countries actually responded quite well. They're the best responders in the world, whether it's Taiwan, Hong Kong, Singapore, South Korea, Thailand, because they experienced SARS or MERS or both, and they set up systems and they responded really well. So we can learn a lot from them. But we have this colonialism is so embedded in our development structures that I think if we want to change this, we're going to have to move from kind of international solutions to regional and local. And that's not the way we think. It's not the way we operate. And I think the Biden administration has some really smart, we have the best development team, I think, that's ever been put together, with enormous experience. And I think they're going to help us get out of this, but we've got to get beyond this. It's a mindset. So I would say, there's an ancient Roman saying, there's hope in death. We need the next generation, like some of the two other panelists, to take over and get us out of the way.
Yeah, and I completely agree on the point around capacity and feel strongly about IP, although, I'm strongly biased there as a, for-profit investor in this space, but, biologics capacity in developing countries, whether it's mRNA or even just for vaccines, which is, really limited. If you look at a place like, Nigeria, they're developing, commodity small molecule manufacturing, and that's fantastic. So they don't have to, and sterile injectables. So things you really need for hospitals and regular care. That's awesome. And antivirals, you really, for some, HIV and other things. So that's fantastic. But biologics capacity is almost non-existent in very poor countries. That said, I think something that, we've been involved with, kind of an investment capacity with the Serum Institute of India for years, the largest vaccine manufacturer in the world. It's in Pune, India. They make, 1.5 billion doses of vaccine, I believe, a year. I think that is a kind of, I know they're kind of a middle income country now, but kind of a triumph of the global South. I don't think people realize how much this single private company in a small city in India is contributing to global health. And so I think there are other examples of like that. And I would love to see the Nigerian Institute, Serum Institute. I would love to see similar efforts. I know in South Africa there's a lot going on, but we're so far from mRNA capacity on the continent. But I totally agree with Mark that would be transformative. Developing local manufacturing capacity and local know-how would be great. And it's come a long way, but it's I think more Serum Institutes is what I would bang the table for.
Don't give up on mRNA yet. I just sent you a note. There's actually a way to do it, and do it now, and do it quickly for because there are closed systems now that make it possible. So maybe cool. We can talk offline.
Yeah, that'd be great.
Angie, if I could just add one more thing,
please,
to draw it away from COVID and make it a little bit broader regarding the legacy of colonialism in global health, is even how we have the conversation. If you look at how the United States allocates its resources, the bulk of the resources is aimed at responding to infectious diseases. The United States and other European countries primarily address approach, I should say, global health from a self-interested perspective of keeping their population safe. Let's help them so they can stay safe. That is a big perception in the global South, that you're just funding HIV, you're just funding pandemics because you want to keep your population safe. People are watching that. They see where our money, is going. But another part of that is who's speaking, who sets the agenda. Why do we get to decide in country X that HIV is the biggest issue? It very well may not be. I've been in countries where they're like, look, I'll take your PEPFAR money, but really what we need is clean water. Like, I'll take your PEPFAR money, but what we really need is maternal health care. So we set the agenda and decide what is important in global health. That within itself is a remnant of colonialism. Rather than approaching it and asking the countries themselves, what is your priority and how can we support that? We say, this is what is important in global health, and this is what we will do. So it's not even bringing them as equal partners in helping them. So I would say even the way we approach global health. And finally, I would say the leaders at the table. You met Crystal earlier. Like I said, I've been in this space for about 20 years, but still the space is dominated by white people. You do not see that many people of color who are in leadership positions in these large organizations. Doesn't mean we don't have the talent. It just means that we're not seen yet as equal partners and ready to assume these positions. So I would say all of those things relate to the legacy of global.
So if I could, and I'm sorry to drag this on, but we're going into different areas which we were going to cover anyway. So just the language of our development is colonialistic and paternalistic, right? Aid is a horrible word. And we refer to the whole area as aid. If you're an African and people talk about, I'm going to come aid you, or I'm here to help, it's very paternalistic. Graduation makes my skin crawl. Yes, we're patting them on the head saying, we now think you're able to manage on your own, so we're going to graduate you. Just the language we use is horribly paternalistic. I would say that people have shifted from HIV now, but I was there at the beginning, and I can tell you if we didn't invest in HIV, nothing else would be possible. The countries were being wiped out, and there's still a massive problem with HIV. So they've been able to move on to other stuff because HIV was wiping out their countries. But you're right, and we have moved there. In the Bush administration and the Obama administration, we actually had moved towards a partnership model where systems were prioritized. The Global Fund's been doing this for quite a while, where you actually sit down and co-plan with the country. That all changed in the Trump administration, where the countries got dictated to again. So we need to go back to where we were before. And again, I think this administration will shift heavily there, but it's really hard to change because of our systems. And if those systems don't change, that's really going to be hard to change all of that. But if we keep using this horrible language, and this is the last thing I'll say on it. So if you talk to people in China, Mexico, Brazil, the people who graduated, we never actually transition out of countries, we exit. They hate development institutions. They hate them because they treated them like children for 20 years and they don't want nothing to do with them. And that is actually, if you sit down and get to know people, which I've been fortunate to do, ministers, presidents, leaders, they can't wait for us to get out. And because that wasn't the case, I don't think 4 years ago. That is the case now. I think we'll correct that. But we have got to change the systems, and they're built for paternalism.
Yeah, not to be the capitalist in the room, but they don't want aid institutions, the paternalistic aid institutions anymore. What they do want is foreign direct investment and technology transfer. They want to actually build in-country capacity. And I saw something in the chat around, more serum institutes still need access to priority vaccine technologies. I totally agree. And I think the format for that should largely be, the Serum Institute striking a deal with biotech companies and having investors support that, as we have. I don't necessarily think it should be kind of a top-down aid-based technology. I think there's a space for that. There are NGOs like Path and others who, help do technology transfer to low and middle income countries. But I think the kind of elegant solution is, the Serum Institute's actually a pretty sophisticated operation. They really do know what they're doing and could, definitely consume mRNA manufacturing capabilities should they acquire a biotech company or strike a partnership with Moderna. And I would just love to see that kind of thing happening with, global investors supporting that as needed, but more of that and less of, hey, India needs mRNA manufacturing. Let's like go in kind of with the cavalry of international aid institutions and try to figure out how to make that work. So that's my pitch for, I think there's a real strong place here for local businesses and, local technology companies.
Great, fantastic, thank you. And I think that brings us into some more of those questions about where to prioritize investments and how to sort of shift the balance of power and decision making away from what we've typically seen in global health with aid and sort of paternalism and development, and shifting more towards investing in and partnering with local organizations and institutions. So I think I'm going to ask next that public-private partnerships are generally right now characterized by collaborations between wealthy countries and corporations in wealthy countries. But we've seen that local companies, like we've talked about the Serum Institute so far, are just as capable as innovating high impact interventions for public health, such as affordable diagnostics and new modes of emergency transportation, for instance. So can we talk a little bit more about why it's important to support and invest in these local organizations?
I think that public-private partnerships happen at all levels in economies and in societies. How people perceive it may be different, but you may see a small public-private partnership look like something like a small startup startup company has created an app that you could use to improve access to care or monitor when a health worker goes to do a home visit. They can actually use the app to record the vitals and all those things. That is a public-private partnership because the private sector has developed the app and it may be used in the public sector. Or you may see public-private partnerships like what AMREF does, whereas you have they train health workers, and after the health workers get to a certain level, they can open their own small clinics. In most countries, the private sector plays a very key role in global health, in providing health. We think of the public sector oftentimes when we think of healthcare in most countries, but actually the private sector plays a key role. I would say one of the biggest challenges is integrating the private sector when we're doing these national planning exercises with countries. We tend to look at the statistics from the public health sector, involve partners from the public health sector, and are not quite as good, I would say, and consistent as involving partners who provide healthcare through the private sector.
Yeah, I guess, public-private partnerships in my world can be kind of, vaccine manufacturing company, a local government. I think something that is, this is kind of a question that we I think may address later in terms of kind of IP related and who funds what, but so much of fundamental science is obviously funded by us, the public, through through the NIH and elsewhere, and in developing countries that's kind of a similar dynamic. As fundamental research is kind of a public good. And so I think when I think of public-private partnerships, virtually all of the vaccines that were developed came from NIH funded efforts, came through universities, whether it was at Penn and ultimately in the Boston schools with Moderna, involved private capital. And then ultimately, hopefully if mRNA manufacturing happens in low and middle income countries like Mark is working on, like there'll be pretty robust life cycle of like all types of institutions being involved. I still don't think we figured out a way to do that kind of fairly and equitably. I feel like people feel pretty strongly that, universities and nonprofit funders kind of get the short end of the stick. And, there's a lot of public goods being created by, taxpayer dollars here in the US that, I think there's a legitimate case to be made that those efforts should contribute to not just, US vaccine supply, but also, what are our values around equity with the use of those dollars? As a taxpayer, I would care quite a bit about the vaccines that I've helped fund going to places who need them, both practically because it's a pandemic, but also just because that's where I think, as a broader conversation, most people would support. So yeah, I mean, I think, and on the kind of low-income country side of things, like, not to return to the C.A.R.E. Institute as an example, there's, examples of these in Southeast Asia, in Latin America, of, often kind of government vaccine manufacturers that have been privatized, for better or for worse, but they're out there, and almost, dozens of countries have these. I mean, those are great examples of, where public-private partnerships have worked, and where they could work better, where, the ministries of health rely heavily on these local vaccine manufacturers. There's definitely an opportunity to bring in, global partners. I think one of the coolest things that I've ever participated in is there's a global health developing country vaccine manufacturer conference every year, where it's basically all global South vaccine manufacturers. So the C.A.R.E. Institute, the Latin American contingent, the Southeast Asian contingent, all come together to knowledge share and strike deals about technology and manufacturing capacity. And I think that's pretty remarkable to see, that kind of cross-pollination of government funders in the global South, companies and technologists in the global South coming together to work on things. And I think that's pretty cool, and kind of a cut away from the traditional aid model of, we're going to come in and give you technology, and we're not going to give you the blueprints, but you can manufacture it in country maybe. So that's promising, and I'm definitely excited for more of that.
Public-private partnerships are hugely important. I've probably started 400 of them between PEPFAR and the Global Fund. I think we've misunderstood the nature of public. First of all, there's this almost crazy notion that the private sector is going to jump in and just give away billions of dollars. Never going to happen. Every board member would be fired if they tried. Where public-private partnerships work with larger companies, I think what Chris is doing is amazing. I mean, what Charles is doing is amazing, and that's the future. And that's the type of thing that the U.S. created a Development Finance Corporation to help with this. There's the UK's developing things that are different, that would be much closer to what Charles is trying to create. And that's what we need for the future. What we try to do in big public institutions with public-private partnerships have been way too driven by the CEO's pet peeve, or short-term things that are relatively small, that are often just used as public relations things that are really difficult to sustain. You have to find something that's in the interest of the company for the long term, and that's in your interest, and match, and just focus there, instead of starting all these little things for that look really good and do nice things for a little while, but really don't work. And I think a great example is a partnership the Global Fund did with Coca-Cola. For a while, people were like, oh, just Coca gets everywhere. Why can't we antiretrovirals everywhere? Let's put condoms on their trucks, just silly things that, not silly, but things that public health people think of that make absolutely no sense from a corporate standpoint. They were never going to send a bunch of condoms out on their trucks. It wouldn't be good for their image, and certainly wasn't going to change any dynamic. So, but what they are amazingly good at is supply chain. So we partnered with them, and they started embedding people in ministries to support the ministries of health and finance and planning to revolutionize the supply chains that the companies had, or the countries had. We started in Tanzania, grew now to 9 countries, I think, under Peter Sand's leadership. So those kinds of partnerships can actually be transformational, but you really have to find what a company is great at, and that they have vested interest in, and that will therefore sustain what you need, and match those. And then importantly, work with the countries, and don't just go in and do it, but co-plan that. That was the ministry, it was at the time, the president of Tanzania. Sadly, the current president just passed away from COVID. He was a COVID denier. One of the several heads of state in Africa were COVID deniers who've since died from COVID. But under the previous administration, it was actually it was all led by the government, to Tiagi's point, that it wasn't us going in to say, you have to do this. So you have to pull those pieces together. But for the future, that's kind of our adaptation of the old model. For the future, what we need is what Charles is doing, and we should be setting up big co-investment opportunities and approaches to allow people to get in. And the last thing I would say from a US perspective is that's what China does, but not in a very good way. And that's why we're losing the development battle to China, even though we put a lot of money in for other things. they provide a package that goes from private sector through to humanitarian. And if we don't start doing that, we even with all the money that we put in, we're not going to compete in an effective way.
Interesting. So I know we're approaching time that we've allotted for questions, but I'd like to just do a quick round of sort of final thoughts. And we've run the gamut really on lots of different topics today, and I'm just in awe of the expertise we have on this panel and just appreciative of everyone's time. So I think in your closing remarks, if you can share your thoughts on, as a generation, speaking to mostly college age university people interested in global health, what goals should we collectively prioritize to ensure a healthier, more equitable future for the planet? So Charles, do you want to go first?
Sure, that's a big question. I mean,
sorry.
Yeah, I probably have less kind of top-down advice in terms of what the planet and then kind of a generation of people should be doing, but maybe more personal advice that I've been given and followed to greater or lesser degrees over the years as you kind of embark on your careers and internships and think about what to do next is like, you know, I don't know Northeastern well, but I think there is a tremendous social pressure and kind of a tremendous very understandable tracking that happens after college towards traditional careers, even traditional careers within the global health space. So, you know, there are kind of safe jobs in global health, you know, that are interesting maybe and impactful on some, to some degree, but, you know, I encourage you to, as individuals, you know, really explore, you know, what makes you excited about this space and kind of do something maybe a little outside of your comfort zone. The greatest experience of my life, I worked in a kind of a horrible finance job right out of college and quit within a couple of months to go live in Haiti for 2 years and work in a microfinance bank. It was the best experience of my life. It changed, you know, my kind of trajectory and interests. And, you know, I think it was really scary at the time to change from this kind of well-paid, secure job in the US, in this case in Washington, DC, to, you know, kind of sell all my IKEA furniture and move to Port-au-Prince, which is trivial in hindsight, but you know, not encouraging everyone to move internationally, although I think it's a wonderful experience after college to get to know another culture wherever it is. But you know, I think, you know, think about your career more as an opportunity to explore and kind of push the boundaries. You're all so fortunate to go to a great school and be in the US and kind of literally be able to do anything after college. And I would encourage, you know, especially in the global health context, you know, read the books, read Bill Easterly, read Paul Farmer, like understand philosophically what you know, what is your view on this field, right? It's like not all global health is the same, not all public health interventions is the same. There's a lot of different ways to do it. And I think, you know, develop a personal conviction around, you know, kind of a theory of change and pursue it aggressively. And I think, you know, that will bring happiness and fulfillment in a way that kind of maybe a safe prestige job won't, just with 10 years of kind of hindsight after college, seeing friends go in different directions. So maybe that wasn't even answering the question, but that's something I would impart on my, you know, 22-year-old self.
Thanks.
Since I didn't see Tianji to kick off her mute, I'm gonna do it. I'll go and then she can go. I actually want to pick up on what Charles said. Don't be boxed in. First of all, I never give advice because advice is what someone would do if they were you, and we're not. All we can do is give you information and experience, which I think Charles just gave a great experience for as something to think about. Just don't. My only view on this is what development will look like in 20 years is fundamentally different from what it is today. In fact, it's not even going to exist as it does today. And it's going to be like 20 years ago, you're all too young, but there was no field of global health when I got started. It didn't exist. So development is not going to exist the way it does today. Countries are growing rapidly, and it's an old model for an old time. We need it for now. We need the resources, but we've got to change what we're doing. So you all get to create what that looks like. and in an integrated way, in a holistic way, in novel ways, using the modern era tools that will also be different between today and now. So if you want to be in this, first of all, just engage, whether you go into development formally or health formally. If you go into business, you can have an impact. If you go into architecture, you can have an impact. And I'll, just as an example, Barbara Bush Jr. Called, not really junior because it was a grandmother, but Barbara Bush started something called the Global Health Corps, which is amazing. There are very few health people in it. There are architects, there are artists, there are engineers. And what excites me about most of the people in that organization and in Africa I work with is young people don't think about the silos we've created in development, and they don't think about the models we've created. Climate change and health go right together. Climate change and gender rights go right together. Gender rights are the foundation of a lot of any change we're gonna have in the world. So as Charles said, think about what excites you. Think about, how you would like to engage from whatever field or career you go into, and do it. And the ability to move and change, all these old systems and patterns that need to fade away is extraordinary, but you're the only ones that are going to figure that out. And if you go into the same patterns of, oh, I have to get my MPH now, and then I have to get my you might have a very good job that is fulfilling, but it might not. You might have a chance for impact that's much, much higher. So first of all, thank you for even caring or engaging, because a lot of people don't. And then find your own path, and you can probably create something extraordinary.
So thank you for inviting me, and particularly thank you for having this discussion. It warms my heart to know that your generation is thinking of these things, and it makes me think things may actually change now because you're thinking of it now. And not only are you thinking of it, you're speaking on it. Not only are you speaking on it, you're acting on it. And those things make a difference. So I'm gonna speak to you as a person of color speaking to a white woman, okay? You asked about equity and how do we get there and how do we make global health more equitable? I'm gonna be 100% honest with you. I see colleagues I started out with who were non-Black, who have risen up the totem pole quickly. We have the same skill set, we started in the same place, but they have opportunities that I may not have had exposure to. And part of that is, quite frankly, is unintentional. People don't think about it. Oh, I know my friend such and such, I'll recommend her for that, And that's how these relationships go, and these how people grow in their professions. It does not mean they're more or less qualified. It just means that you have those connections. Now, I want to say, if you want to really bring equity, leverage your connections. Intentionally think about people of color when you're trying to have coffee with someone and you have someone new in the office. Invite a Black person, invite a Latino person, give them the inside scoop, help them, introduce them to your colleagues, recommend them for panels, recommend them for positions. That's how the changes will happen, because we don't have the connections, we don't have the power. So we need you to be our allies to say, I know someone who can do this. I know someone great who can do this. So I would say the fact that you asked that, huge hand clap. Thank you so much. My people, thank you so much. And continue that kind of work and that mentality. Create allies, I will say. Be conscious of your actions and who you interact with. Refer, refer, refer. Share those informal dialogues, have lunch with these people, share your networks, and the changes will come. Thank you.
Thank you, everyone. I'm hoping I could take 5 additional minutes of your time. If anybody has to jump off at 12 or the top of the hour, feel free to, but we do have a couple questions I want to get to in the chat. And it's honestly really hard for me to pick which one to start with. So I think I'll start with a question that came pretty early on from Brooke Baker. We have a confluence of biopharmaceutical companies' control over supply, price, and distribution, and narcissistic nationalism. narcissistic nationalism in rich countries. As a result, we have an artificially restricted supply, needlessly high prices, and grossly inequitable distribution of vaccine, diagnostics, and medicines. And do you as panelists support the South Africa and India intellectual property waiver proposal at the WTO? And how do we force governments and companies to allow expanded manufacturing of vaccines in low and middle income countries?
Yeah, I'm personally not up to speed enough on the specific IP issues and what the asks are to comment on that specific proposal. I think in general, I am against these IP efforts. I think it's so much more valuable to try to develop in-country expertise such that, I think in this emergency situation, I kind of understand why, there may be a desire to, let's get the mRNA code to low and middle income countries. Unfortunately, knowing what I do about biologics manufacturing, it's enormously complicated to do. And I would almost rather spend, and I guess this goes back to a question I had earlier, is like, are we better prepared than we were a year ago for pandemic? The answer is no. Like, almost in parallel to Project Warp Speed and everything else, we should be, building mRNA manufacturing facilities all over the US, all over the world. We know how to do it now. The know-how Moderna has developed is, goes far beyond IP. So even if you kind of had the open book on Moderna's IP, I think you probably couldn't make their vaccine. And that goes for US companies as well. So I would be strongly in favor of, spending, we just spent $2 trillion on a variety of things domestically. I mean, just a fraction of that could kind of radically change our ability to respond to the next pandemic. In this pandemic, like Mark said, this is going to be a chronic viral infection for years to come. So I would strongly put an emphasis on like health systems strengthening, but health systems R&D strengthening as well, and less so on kind of blowing up IP, because there is a real argument to be made there that like, that's not going to work. That's just a kind of an untenable political problem. Now, I'm not a politician and I'm not on the board of Moderna, but I think there's almost a zero chance that happens. So in the way that I understand it. So I would be very pro kind of taking the investment approach of like, let's build capacity elsewhere so we don't need to rely on US companies to, invalidate their patents to get things done.
Great, thanks so much. I think for the sake of time, I'll do a few more questions. We have a question from Shamila Jivrov, and she says, as a Tanzanian national having relatives in Tanzania, we would hear of the number of deaths daily, but the numbers being reported did not support what was actually happening. Why do countries not get called out on a global scale for falsifying numbers, or what might actually be at play here if it's not falsification?
Well, I think Tanzania has gotten called out pretty significantly. I'm sorry if you haven't seen it, that the president, now former president and deceased president, they just weren't counting. They wouldn't, for a long time, they didn't do a single test. So yeah, you didn't have any, it was kind of the Trump approach, don't test and we won't know it exists. It's like saying I'm not going to get older because I'm not going to pay attention to my birthday anymore. I mean, so but Tanzania has gotten called out quite a bit, as have a number of other countries who haven't done things they should have or have just ignored, including the United States, which got attacked pretty heavily, rightly, I think, for how we handled the response or didn't. But I think the problem is everyone's unlike other pandemics or this one has affected every country. And this is part of the problem with why we have such a bad global response. Everyone's fighting their own epidemic and are struggling to engage globally. But there can always be more accountability, but I just can assure you that people are very conscious of what is happening or was happening in Tanzania. Let's hope that changes.
Can I just piggyback on that a little bit? I think the question also responds to the broader issue of how we function as an international community. So the World Health Organization is the global health authority of the world, right? The problem is that countries have not voted to give the World Health Organization any kind of enforcement or investigative authority. So the World Health Organization plays this very tempered role where they say, they may say things in coded words to express how they feel about something. So the World Health Organization has certainly, and in one of the most forthright ways that I've seen, made comments about Tanzania and how it's not responded to and participated in the world and shared virus information and all that. So they have said something, but it begs to the larger issue. You know, earlier in the outbreak, the Trump administration complained about WHO's response to China and essentially said, you know, that the World Health Organization was, you know, kowtowing to China. And the challenge is that the World Health Organization operates at the behest of the country, right? They can't go into a country and say, hey, I heard you had an outbreak. Let me see what's going on. Can't do it. The country has to allow them in. WHO has to request the information from the country, but the country has to voluntarily give it to the World Health Organization. We don't have any authority that exists in the world to call out a country per se. The World Health Organization does kind of have that authority, but remember, on the other hand, it's also a member organization, right? So Tanzania is a member of the World Health Organization. China is a member of the World Health Organization. So its job is to represent its members and to be the global health authority. And so what your colleague was asking sort of gets to this deeper question of how are we as a world going to put in these measures of accountability? We don't want to give up our sovereignty, right? Because there's a lot of discussion about, well, the World Health Organization should be able to go into a country and do something. And when people ask me, they always say, well, what about if it was the United States? Would you want the World Health Organization to come into the United States and start to investigate what's happening with us and tell us what to do and how to respond to our outbreak? And usually people don't want it, but they want it for other countries. So I think what your colleague is getting to is this whole issue of authority, right? Authority to respond, irrespective of what the country wants, authority to investigate, irrespective of what the country wants. And are we moving to that point? We're seeing what's happening with COVID. Are we moving to that point as an international community where somebody should have the authority? Somebody, and I don't mean like a person, but a body, should have that type of authority. So that's a big debate going on right now.
Thanks so much. And I think I'll ask one more question. Question that we've only touched on just very briefly, but could we elaborate more on the intersection of the climate crisis, global pandemics, and systemic inequality, or inequity, excuse me?
We need a new panel.
I know. Also, I really wish we had an additional hour or multiple hours here.
Well, I mean, there are some clear things, right? So climate change is affecting global health in a dramatic way and will continue to do so. So we're seeing malaria in places we have never seen it because it's getting warmer up as you climb up mountains where, you know, we hadn't seen it because it was too cold for the mosquitoes to survive. We also, because of you know, climate change is what's the cause of climate change: urbanization, use of people living together, lack of access to energy, lack of access to a lot of things that leads to an attempt to grow your economy without clean sources that leads to burning and use of fuels and things that we all went through in the wealthier countries have gone through. And that affects people's health, right? So you have pollution, you have crowded settings where disease can spread faster. And these are actually increasing our pandemic risk significantly. Also with climate change, we're moving because of people's, our need for space because of population growth, which is very much a health issue. We're getting closer and closer to animals, and that increases the risk of zoonotic jumps and spreads. So the causes of climate change are very much linked to health issues that cause health, but then in a reciprocal way make climate change worse. And many things we use in health, plastic syringes, things like that we need new technologies for, then contribute to the disasters that we're doing to our climate. Beneath every issue is inequality and gender inequality. You know, if you think about it, if in many countries in the world, the birth of a girl isn't registered still, because it's not an event that you would care about because it's a girl. Imagine if everyone had everyone in the world had equal opportunity for their ideas and for their full potential to be realized. What we are missing in solving the world's problems by not giving that opportunity to women, to anyone who doesn't have the potential to fulfill who they are and what they could be. How many Einsteins are we missing? And so unless you have a fully equal world, we're not getting people who can solve the problems the access to solve them, but we're also distributing resources in a way that will never allow us to solve our problems. And so, but there's a chance with a new generation, there's a chance that we will see the world in a different way, see these connections, which are so clearly there, but which don't exist in our siloed way of thinking and acting. And I again go back to this coming generation is going to have to solve this problem because we are too embedded in our ways otherwise. All you get is pablum, So now every global health document has to mention climate change, but no one really means it. It's just kind of there. Everything has to mention gender equality, but whether or not anyone really cares about it, it just has to be there. It's just to be, correct. We need to shift from that to what the SDGs actually call for in the chapeau, which is person-centered approaches to development, because development is not, you can't solve health and not inequality. You can't solve inequality and not health and education. You can't do any of it without having it all at the same time, which sounds complicated, but it's doable.
I think it'll be helpful to unpack the word climate change. I see the word climate change used to describe almost everything. And there's a climate change, and there's environmental degradation, and then there's urbanization, and there's a number of things that people use to say climate change. But climate change is really describes just one thing, which is the change in the temperature and weather patterns, right? So we're talking about what may happen with drought and floods. We're talking about what might happen with warming of weather. We may talk about what some areas may experience in these severe weather patterns. That's all climate change, right? But when we talk about environmental degradation and when we talk about our human behaviors, those things can impact climate change. Now, the reason why I'm raising this is because we can impact climate change. We don't have to keep using it as a word as something that's a foregone conclusion, right? So the issues that Mark was raising in terms of how we use our forest resources, how we use our resources to respond to health, all those things can ultimately impact the climate. But we ourselves can take actions in how we respond to our environment to impact climate change. So, I think there's the obvious things, that Mark raised, but what I would like to do is unpack it so we feel empowered to do something different. There are novel solutions that are happening right now that we can do, in terms of using our solar energy better, using our geothermal energy better, using renewable resources in our health commodities. All those things can be done now to make a big difference later to avoid this inevitable climate change. So I just wanted to put that out just in a very broad way, not anything in particular. Just
Thanks, everyone. I think I'll now hand it back over to the organizers to transition us to the next thing, but just want to thank you all for your time and a fabulous discussion. Really appreciate your time. Thanks.
Thanks, everyone. Thanks for having us.
Everybody, thank you so much for tuning in so far. I want to thank Ms. Lander for her very engaging and interesting keynote speech, Charles Petty, Dr. Daibo, and Tiaji for taking a lot of their valuable time to educate and participate in these important discussions. We're about a third of the way through today, and we're going to take a 1 hour break.